Good evening, everybody. Paul GP Grand Rounds COVID-19 vaccination update, information on Astrazeneca, Pfizer and Moderna for primary carers in southwestern Sydney. I'd like to begin by acknowledging the traditional custodians of land on which we meet today in our various places for Zoom. And I'd like to pay my respect to the elders past, present and future and extend that respect to those in the meeting identifying as Aboriginal Torres Strait Islander people. Housekeeping points. This session is recorded as per the pre-recording earlier on. Everyone is muted throughout the session except presenters. So if you've got any questions, please type it in the chat box. And inform us through the chat if you're sharing the same login with your colleagues so that the PHN team can issue certificates accordingly. Please complete the online evaluation at the end of the session as feedback assists in continued improvement. That link will be posted in the chat. All participants are required to stay for the duration of the meeting if you want to get your points and your certificates, and they'll get issued within the week. We've got two speakers tonight, the first of whom is Dr. Hima Vidam, who's a senior staff specialist in respiratory and sleep medicine department at Liverpool. And since working in southwest Sydney, she's established sleep and respiratory failure services at Liverpool Hospital, and is also heavily involved in research, as well as being the co-director of the research and clinical academic group of SPEAR, the Sydney Partnership for Health, Education, Research and Enterprise. Her work over the last 16 years, including establishing the sleep investigation unit at Liverpool, as well as the inpatient respiratory failure service, the area-wide multidisciplinary motor neuron disease clinic, and supervising advanced training in sleep medicine. But of course, now in our current pandemic times, she's part of the team caring for COVID-19 patients, of which there are 7 wards at Liverpool at the moment. Our second speaker will be Professor Raina McIntyre, who's the head of the Biosecurity Research Programme at the Kirby Institute and University of New South Wales, and a Professor of Global Biosecurity and NHMRC Principal Research Fellow. This talk is scheduled to be about 90 minutes, but will end before that, and questions can be done on the chat towards the end of the meeting. I will mute myself now and hand over to Dr. Vidam.
Thanks very much, Lance. I'm going to be doing a brief overview of COVID initially, and then we'll talk a bit more about the vaccinations. The main things I was going to talk about is common symptoms and presentations and the time course of illness, the different spectrum of severity of illness of COVID, some of the indications and contraindications with regard to the vaccines, and the longer term outlook. And then I'll also be just talking about the impact of COVID on southwest Sydney and particularly Liverpool Hospital. As everyone's probably aware, COVID-19 is an infectious disease caused by the SARS-CoV virus, and the Delta strain was first identified in India in December 2020. It has become the most prevalent variant there and in several other countries. The Delta variant is a variant of concern that poses issues for disease control and management due to increased transmissibility, severity, and vaccine resistance. It certainly can be associated with more severe acute disease and is more likely to affect younger people, and we've definitely seen that this year. The risk of hospital admission is approximately double in those with the Delta variant compared to the Alpha strain. And the risk of admission is particularly increased with those with comorbid conditions. The dominant mode of transmission is through infected aerosols and droplets released while breathing and coughing. The symptoms, the ones that everyone has mentioned over and over again, are cough, fever and sore throat, in addition to dyspnea, either new or worsening over baseline. But in addition to that, certainly patients, and we're seeing this quite a lot, may present with a large variety of symptoms, including myalgias, headaches, diarrhea, nausea and vomiting, anosmia and other smell abnormalities, rhinorrhea, chills, rigors, confusion, fatigue, chest pain or pressure. And when you look at that list of symptoms and how they really range, they include many of the common symptoms that we all experience fairly regularly. You can see that in the current situation, really anyone with these symptoms needs to be tested and isolate until it is proven that they don't have COVID. In terms of the COVID illness itself, it really can range from being asymptomatic to going from mild, moderate, severe, or even critical. And there are a number of factors which determine that, some of which we understand, some of which we don't. This is a lovely slide that was published a while ago, and I think it really does a lot to explain the way we see the way presentations occur. In terms of the actual illness itself, initially after exposure, people develop symptoms 4 or 5 or 6 days later. So they initially have their incubation period during which they're still infectious. Then in those who have patients with mild infection, the host immune system is capable of controlling the infection. They often get unwell over 4 or 5 days, at which they reach a peak and then get better over the next 4 or 5 days as well. So usually by about 10 or 11 days, they're getting over their illness. However, in people who get moderate to severe illness, the immune system has a different response, which can lead to organ damage, intensive care unit admission sometimes, and even death. And these patients, rather than the immune system controlling the infection, can go on to develop acute respiratory distress syndrome. And so for those who develop moderate or severe disease, it's usually really in the second week of their illness that we see that they present to hospital or start becoming short of breath. And those who have milder disease can then improve still, but those who develop very severe disease go on to be unwell for quite some time. During this period, the viral genome is replicating from the time the person is infected, and that peak is really in the first few days and then subsequently goes down. The way we really have been managing COVID illness in our community and in our hospitals is based on a definition of disease severity. Mild illness is really, as you would expect, patients who either have no symptoms or have mild upper respiratory tract infection symptoms, and they really have no significant shortness of breath and certainly no reduction in oxygen saturation. Moderate illness is when we start to see patients who are presenting to hospital, and it's patients with respiratory or systemic symptoms. But these people are still usually able to maintain an adequate oxygen saturation of above 92% with nasal prong oxygen of up to 4 litres a minute. And they can still be unwell with a fever, clinical or radiological signs of lung involvement, but they usually don't have clinical or lab indicators of severity or respiratory impairment. The people we mainly see in hospitals, which is the opposite to in the community, are those who really present with severe illness with a respiratory rate of greater than 30 or oxygen saturation less than 92%, especially even despite nasal prong oxygen. And then if that people require more invasive support with non-invasive or invasive ventilation or have other systems down, then they certainly need intensive care unit care. We are aware of some of the risk factors for severe disease, ICU admission and mortality, and these really come under and can be categorised as underlying conditions, the way they present, and laboratory indicators. And in terms of the underlying conditions, older age has certainly been recognised to be associated with more severe disease, as is a number of the common comorbidities, including hypertension, cardiovascular disease, COPD, diabetes, obesity, and malignancy. There are factors on presentation as well that are associated with a more severe disease, and these include a higher fever of greater than 39 or dyspnea and a higher SOFA score. Lab markers that we look at include a neutrophilia or lymphopenia, a raised lactate or LDH, and another number of other inflammatory parameters, including the CRP or ferritin. I got to the end of preparing this talk and realised I didn't have any radiology in it at all. So I put this slide in because I thought it is worthwhile recognising that one of the main things that we're dealing with here is a pneumonitis that people developed. And this is just one of the many sort of patterns that you can get, but generally people get patchy changes in both areas of the lung, and the extent to which this can occur really determines how severe their illness becomes. When I was looking at preparing this talk, I came across this document, which you may all be incredibly familiar with, or I'm not sure if you are or not, but it's the home care guidelines for adult patients with mild COVID-19. And I just thought I'd mention it because I really thought it was an excellent document in terms of how patients how people can be cared for in the community with mild COVID. I guess the important thing to recognise is when the majority of people are being cared for at home, it is useful to have an escalation plan, and that's basically a way of which these patients can be monitored and can be transferred to hospital if they develop signs and symptoms suggestive of moderate or severe COVID. The opposite side of the flip coin is what are the criteria for admitting someone to COVID, bearing in mind at the moment 30 to 50 people are seen every day in the Liverpool Emergency Department, of whom about half are sent home after they're assessed and a plan's formulated. The reasons why people get admitted is if they are hypoxic with a saturation of less than 94 on room air, if they have any features of moderate or severe illness, and in particular if they have any comorbidities which places them at an increased risk of severe illness, particularly a greater age or being Indigenous or cardiac or respiratory chronic disease, an immunocompromised state, including diabetes, or if they're on any immunosuppressive medications, pregnancy or morbid obesity. Other factors that determine whether people are admitted depends on whether they're dehydrated or whether they have an inability to tolerate oral fluids. And we've certainly had a number of people admitted to hospital due to the GI symptoms and the fact they can't eat and drink. The other reason, which is more common than we might think, is if they've got an unsuitable home environment for self-care or self-isolation, and if they're unable to be admitted to an alternative facility, for example, the special hotel accommodation. And this has certainly been an issue at times when the accommodation space is less than the number of patients in the community. In terms of the in-hospital treatment, the oxygen, it's really supportive, and as well as certain medications that we know can help in this condition. The in-hospital treatment, we aim to keep the saturation greater than 92%. And if their saturation does drop below this, they're started on dexamethasone for 10 days. They often don't stay in hospital if they have moderate disease for that long, so they're discharged on dexamethasone for a few more days. And this often does have a significant impact on their diabetes. So you may see a plan in action about what to do about their diabetes medications when they're discharged. If they present relatively early, they may be commenced on remdesivir for 5 days. And if they develop severe illness, they certainly can be commenced on most likely baricitinib, or if there's contraindications, tocilizumab. And I can talk about those more if we have time or people want. If people then go on to develop very severe COVID, they are supported further with non-invasive and invasive ventilation. I thought it was worthwhile mentioning that a lot of effort is going into caring for all of these patients, and it has had an impact in that the vast proportion of people survive. These figures may be a little bit out, but they were the numbers I could find when I was preparing this. And the mortality in New South Wales has been 252 deaths out of 47,000 cases, which is 0.5%. And the mortality in Australia as a whole has been 1,102 deaths of almost 77,000 cases, which is 1.4%. It's also important now that we do also need to look at the long-term outcomes, though, in that a proportion of these patients may have long-term symptoms. And we are now starting to see some longitudinal data about what happens at the other end. And this is just from one study looking at a cohort 1 year after they were discharged from hospital. And in this group, 30% of people still had dyspnea at 12 months, 26% had anxiety or depression, but importantly, a lot of them had returned to their work and their life after being in hospital. It was recognised that COVID-19 survivors, when compared to matched controls at 12 months, had more prevalent symptoms than did the controls. I thought one of the things that was worth discussing here that probably causes quite a lot of angst is when patients can come out of isolation after they've been unwell with COVID-19. Essentially, when every patient's diagnosed with COVID, the public health unit is involved, and will contact them about when they can be isolated. And they generally see this in 3 different categories. The first category is confirmed cases who've remained asymptomatic. And in that situation, they can be released from isolations if at least 14 days have passed since the first positive test and no symptoms have developed. The second case is people confirmed cases with resolution of fever and acute symptoms. So they can also be released if they meet all the following criteria. At least 14 days have passed since the onset of symptoms and they've had resolution of fever and substantial improvement in their symptoms for 72 hours. The last group is the most difficult without complete resolution of fever or acute respiratory symptoms. But in that case, the person can be released from isolation if they meet both of the following criteria. At least 20 days have passed since the onset of symptoms and they're not significantly immunocompromised. The last group is if they are immunocompromised, and in this group, they have to meet all of the criteria below. At least 14 days have passed since the onset of symptoms. There's been resolution of fever for 72 hours. There've been substantial improvement in respiratory symptoms, and they have 2 negative swabs a day apart. I guess the important thing to recognise from the important points from that is the public health unit do contact all of these people about when they can come out of isolation, and they have these deciding factors on which they make the decision. The second thing is the vast proportion of people are released from isolation without having a swab at the end of their illness. In terms of the current care in Southwest Sydney, when someone has a positive COVID swab, that information, the public health unit notifies the community health team through the patient flow portal. And everyone is contacted by the nurses in the community and their risk profile is assessed. The high-risk patients are referred to the COVID medical response team, which is a team of doctors who work in parallel with the nurses. It is important to recognise that there's no automatic referral to the medical team who are involved with phoning, who make 50 to 100 phone reviews a day. It's just that these patients have been flagged by the nurses. Patients who have just come out of hospital or been seen in emergency departments can be flagged for medical review. And the way this works is they are referred to the Intake Information and Intervention Hub, or III Hub, as everyone seems to call it. Well, high-risk patients are seen by reviewed by doctors. But if the nurse rings up a patient and they're unwell, then they're directly referred to hospital or an ambulance is called. And the way to refer people to III Hub is through this link, which probably most people are aware of, but I thought it was worth mentioning. I think one of the things that we've all become aware of is things that we already knew in part, but has become a much bigger part of our life, and that's infection prevention and ways to prevent COVID in our world. There's increasing evidence that talking, shouting, coughing and forced expiration increases the aerosolization that can spread COVID droplets. And there's increasing recognition of the importance of indoor ventilation and things like that in terms of limiting the spread. But the messaging we've been hearing for the last 2 years, and which is correct, is the ways that we can all work together to prevent COVID spread is the simple things that we have been doing and need to continue doing, which is social distancing, using personal protective measures, using masks and vaccines, and which we'll talk about a bit more. The one point I wanted to make in this talk is about vaccination. As a respiratory physician working at Liverpool Hospital, I've had a number of discussions with various people about this issue. And in my mind, the one thing that comes up over and over again is that everyone should be able to have one of the COVID vaccines. And vaccination is an important key to overcoming this pandemic. When I was thinking that I was talking about indications and contraindications, I thought, well, really the indication is to prevent COVID infection. So there's a strong indication for everyone in the community to have the COVID vaccine. The current recommendations from ATAGI is that the Pfizer vaccine is for those, is recommended for those aged under 60, including now 12 to 15-year-olds, and the Moderna vaccine can also be given to 12 to 15-year-olds. The main sticking point has been that the Astrazeneca, that for people aged 60 and over, they are advised to have the Astrazeneca vaccine. This is probably the only busy slide I have, but the one point I wanted to make from it is that most of the side effects of the vaccinations are really are relatively mild in terms of local injection site reactions and systemic symptoms like being unwell at the time or the few days after you have the vaccination. And I have to say that from what I've seen, people seem to get more sick after the first dose of Astrazeneca and seem to notice the second dose of Pfizer more. But in terms of the other adverse events, they're very rare. Anaphylaxis can certainly occur with the Pfizer and the Moderna and with some components of AstraZeneca. But the main other rare side effects is myocarditis and pericarditis, which seems to be much more common in young people and particularly young men with Pfizer, and I think also with Moderna. The very rare complications that we've heard a lot about in the media include thrombotic complications associated with thrombocytopenia, and that includes cerebral thrombosis and splanchnic thrombosis, and I'll talk a bit more about these, and Guillain-Barré syndrome, which is also very rare. Based on these, the ATAGI has published that the contraindications to the AstraZeneca vaccine include these, if you have already got a history of these rare thromboses, including cerebral, splanchnic thrombosis, and also if you've previously had heparin-induced thrombocytopenia. The other group that for whom AstraZeneca is contraindicated is those with antiphospholipid syndrome with thrombosis and or miscarriage. They do note, though, that people with antiphospholipid antibodies with no clinical manifestations like thrombosis or miscarriage are not considered to have the syndrome and therefore may have the AstraZeneca vaccine. I guess the corollary of that is patients with any other sort of chronic illness who are aged over 60 can and should have the AstraZeneca vaccine, including those with the following conditions. And the reason I bring this up is at least once or twice a week in my clinic, I have a discussion with one or more people about whether they should be vaccinated with their chronic illness. So people with COPD, asthma, cardiac failure, renal failure, muscular dystrophy can have the AstraZeneca vaccine, and people with pulmonary emboli who have not been diagnosed with antiphospholipid syndrome can also have the AstraZeneca vaccine based on the information we have. It is worth knowing that the risk of the thrombotic events is very rare in terms of if you're over 60 years of age, the estimated risk of the thrombosis syndrome per 100,000 is between 1.4 and 1.9 people. And it's slightly more in younger people. I think often a picture is worth 1,000 words in that when you compare the risk of dying from a blood clot after a dose of the AstraZeneca vaccine with the annual risk of death from other activities, I think it does put it in perspective in terms of the risk of the AstraZeneca vaccine is 0.5 per million. The risk of a lightning strike is just slightly less than that. And the risk of dying from a pedestrian accident or a car accident is much, much greater. So I guess in terms of looking at risk and benefit, many of the things we commonly do are much higher risk than the AstraZeneca vaccine. I thought this was another good way of looking at it, and I won't labour the point more than I have already, but essentially once you get to anyone over 30, but certainly over 40 in a high risk situation, which we are pretty much in now, it's quite clear that you're preventing deaths and the benefits outweigh the risks of the AstraZeneca vaccine. Having spent a bit of time on that is something dear to my heart, I thought I'd talk a bit about the current situation in Southwest Sydney. In the last 4 weeks, we've had almost 10,000 cases and almost 800,000 tests. This is an infographic which really goes through some of that information, saying that since this Delta wave, we've had almost 12,000 cases, of whom almost 8,000 are in isolation and almost 4,000 have recovered. It's important to recognise that about 60% of these people are aged between 20 to 59. So this is a very different population to what we saw last year. And that's certainly what we're seeing in hospitals. In terms of where the biggest areas are, in the last 7 days, and this was a week old, So the information might be slightly different. 839 people in the Liverpool LGA have been diagnosed, and 1,400 in the Bankstown area, as well as 614 in Fairfield. So certainly we're seeing a large number of cases in southwest Sydney at the moment. In terms of how this impacts on our healthcare system or the hospital system at the moment, about 4,100 people are being cared for in the community. And this has resulted in, and when I spoke to our ED staff earlier today, this has resulted in 30 to 50 presentations to the emergency department each day at Liverpool Hospital alone. And I was told that of these, there's about a 50% admission rate, which is in keeping with what we're seeing. So we're getting 15 to 25 admissions a day with COVID. At the moment, and Zinta can correct me if I'm wrong, there are about 160 patients at Liverpool Hospital, and that was a couple of days ago. I think it's a bit less now. There's about 33, 35 patients in ICU, and of those, about 20 are intubated. In terms of the changes at the hospital, we used to have one respiratory ward, but currently we don't have a non-COVID respiratory unit, as non-COVID respiratory patients are being looked after at Bankstown Hospital. We've now just recently expanded to 7 COVID wards plus ICU, and we may go up to 9 COVID wards. Our ICU is in the process of expanding to 60 ICU beds. I just leave that. There's a number of challenges of working in such a changing environment in terms of managing the staff training at all levels, medical, nursing and allied health, managing the changes that need to be made to the environment in terms of ensuring there's adequate ventilation. And Jonathan Williamson and Zinta have been very busy in ensuring that this is the case, in installing HEPA filters and viral filters in the rooms where the patients are, inserting the plastic portable doors to ensure that previously open spaces like the 4-bed bays are now closed spaces. There's been issues with equipment in terms of making sure there's enough high flow oxygen delivery devices, CPAP machines, and certainly last year, enough PPE. I just thought I'd finish by showing some pictures of Liverpool Hospital at the moment. And certainly this is one of the portable HEPA filters that's been inserted in a lot of the single rooms to convert non-negative pressure rooms into something similar to a negative pressure room, because it basically means the air is being sucked out of the room to create 5 exchanges an hour, which is similar to a negative pressure room. The other big change is any space where COVID patients are, rather than being an open space, if it's possible to convert it into something that's sealed, this is occurring on. And so every time a new ward is being started, all of these changes need to be thought about. It's certainly been a very dynamic workplace in that we've all gotten used to wearing full PPE when we're liaising with patients, in terms of a mask, eye protection, a gown and gloves. We've also gotten used to different forms of communication in terms of talking to patients who are in single rooms, using our phones or baby monitors, with interpreters as well for a large proportion of the time. And I don't know if you can see this was someone's joke, I think, but it certainly is the way we've been seeing things. You better watch out, you better not cry, you better be safe. I'm telling you why, COVID's come to town. So that's in our room where everyone dons and doffs in our ward. So in summary, I hope that was helpful. I wasn't exactly certain what information would be the most useful to you guys, but I thought the important things that it is worth recognising is that there's a range of disease presentations from mild to severe. 15 to 20% of patients are hospitalised. The mortality in New South Wales is relatively low at 0.5%, but it has presented multiple challenges to our community and our healthcare system. And in terms of the primary care role, which I think is important, it's in diagnosis, it's in the management of mild disease and the prevention of disease through vaccination. and it's in looking after patients in the long term with their ongoing symptoms. I might leave it at that and then allow Professor McIntyre to talk a bit more about the issues of Delta and the public health issues.
Did you want to take questions, Hima?
Yeah, I can. I just didn't know if whether you wanted to do your bit first.
How are we going for time? We've probably got plenty of time.
What is your recommendation if a patient was asymptomatic for 14 days and released and developed symptoms 2 to 3 days after release from isolation? Do they need another test or isolate again?
Hima, I wrote a response to that in writing. If I
Okay.
only because there's always curly questions, but the general understanding is if you're sure that someone has recovered from COVID, it's believed that they're unlikely to catch COVID again within the 6 months, and retesting can in fact be confusing because you may still have a positive PCR even when they're no longer infectious. So we generally don't recommend retesting or re-isolating after someone's been confirmed convalescing. That, of course, depends whether you're absolutely sure about the disease onset dates. So the day 0 of COVID illness is defined as the first day of symptoms. If your person is asymptomatic, then you define it as the first day of testing. They shouldn't really develop symptoms more than 14 days after their test is positive, is my understanding.
Well, thank you. No, that's fair enough. So that goes along the lines of the reason, one of the main reasons why in most categories they're not recommending a repeat swab is that it actually can often confuse the issue rather than clarifying it.
The question about the vaccination, when do you vaccinate someone post-COVID, is something we're still waiting guidance on. So we believe that you should not vaccinate within 1 month of COVID infection, and possibly you don't need to for up to 6 months because of this native immunity you get after being infected. However, not everybody agrees with that interpretation, so I'm waiting for a definitive answer. It will be something between 1 month and 6 months post-infection, I believe.
What is the role of sotrovimab in mild COVID with risk factors? Well, I guess the answer to that is we are determining the role of this new medication at the moment. Certainly it's in specific instances when patients are presented to the emergency department or where we have a clear exposure in the emergency department, sometimes it can be helpful. As far as I'm aware, and I could be corrected, there is no clear-cut guidelines at this stage as to who should be receiving sotrovimab. One of the other issues in terms of sotrovimab is the logistics of actually administering this medication. And I'm also not aware that those have been completely overcome at this stage because it is an intravenous medication, and the issues of getting the COVID positive person to the place where they're getting it and then going home again safely are some of the issues that are being worked through. Did you have?
I can comment. There is actually a flow chart for indications for sotrovimab. If I'm correct, it's put out by the New South Wales Therapeutic Advisory Group. And unfortunately for us at Sydney South West, it includes just about every single comorbidity that our patients have. It covers obesity, diabetes, renal impairment. It could be indicated for just about everyone. So yes, I think there is a role. The question is, how are we going to administer it? It was thought to be a GP-centered program, which I'm not sure is practical for an intravenous infusion on a COVID positive person. So we have selectively used it where we can on inpatients, and we are looking at a way of giving it to patients who present at the ED, but we haven't resolved how to do that and keep patient flow through ED.
Sorry. Okay. What is the recommendation for antibiotic oral steroids for a patient who has mild to moderate COVID symptoms and has been doing self-isolation? I mean, if someone has proven COVID and is isolating at home, I don't think an antibiotic or oral steroids are indicated for that person unless there's some other reason they should have them. I mean, unless they're an asthmatic and you think they're having a flare of their asthma, or there is some other indication, I wouldn't normally give them antibiotics or oral steroids.
In fact, there's harm if you give steroids and they're not hypoxic. That's been demonstrated. So you shouldn't be giving steroids to patients with COVID unless they're hypoxic, and we use 92% SATs as our threshold to commence dexamethasone for inpatients.
Are side effects expected more than 4 weeks after a jab? I'm not aware that people I'm not aware that people would expect side effects 4 weeks after the AstraZeneca. I mean, I think very rarely you can develop some side effects up to 6 weeks in terms of the thrombotic complications. But generally speaking, if people are having side effects after that time, I think it would be unwise to attribute it to the vaccination. Some other states have changed their guidance on Pfizer for above 60s. We still have some above 60s who are resistant to AstraZeneca and waiting on Pfizer or vaccination, in spite of a lot of encouragement. Do you see this changing in New South Wales? I personally don't see it changing in New South Wales. And I think that's one of the reasons why I spent a bit of time on talking about the AstraZeneca vaccine, because I do think the messaging has been confusing. But I think I think the evidence is quite clear that in the current climate, for the people, unless they're in that group where there's contraindications, I think the AstraZeneca vaccine is safe, and certainly the benefit outweighs the harm. So I think we really need to work on our communication with the public. I'm not sure that the indications are going to change. What is the current approved treatments for patients with COVID-19 infection at home?
There are no currently approved treatments there for COVID-19 infection at home, except for sotrovimab, I suppose, if you can get it. It's symptom control.
Can you discuss the sudden deaths at home of COVID positive people? I think it's difficult to discuss the deaths of the COVID positive people in detail because I don't have the details of those cases. I think broadly we are aware that people can become can be unwell and not recognize how unwell they are. And that's one of the reasons why we do have the community nurses calling and the doctors calling. One of the things we have implemented is for a proportion of people is that they do get pulse oximeters at home. And this is based on risk stratification again. One of the issues is we have a couple of thousand oximeters, but we have several thousand patients with COVID in the community. This certainly, I think, is something that is helpful because the patients can use the oximeters, and then the doctors who are ringing them up or nurses can ask them what their oximetry is. There certainly have been cases where patients who are quite hypoxic have not recognised how unwell they are. The only other thing I will say is, I mean, we have a very low threshold for suggesting that people come to hospital, and we have, I think, a relatively low threshold if we're at all concerned to admit people to hospital with their COVID illness. So one of the other messaging I would say is if people are concerned at all, they should be seeking medical advice. What are currently done that? Once out of hospital after COVID infections, how long do they quarantine, and how long are they contagious for? I think we did talk about that in terms of the fact that the public health unit will contact them as to how long they need to quarantine. And it's pretty much based on those 3 different categories. If they're asymptomatic, after 14 days, the public health unit will suggest that they can come out of isolation. If they have had symptoms, certainly still after 14 days of the onset of symptoms, and provided there's been resolution of the symptoms and no fever for 72 hours, they can often come out of isolation. If in the more complicated groups, it's after 20 days that they can come out of isolation. But basically, all of the patients should be contacted by the public health unit and given advice about this. And this is one of the difficulties we're having with the patients admitted to hospital as well, is to convey that even when they come out of the COVID ward, that they are now not infectious and can go to other wards and other hospitals. If a patient is having dialysis, when to provide the COVID vaccine, any time difference from renal dialysis and vaccination. I don't specifically know the answer to that, but I do know that in the dialysis centre at Liverpool Hospital and Campbelltown Hospital, they're actually working on a program where they can give vaccinations to the dialysis community. So I think they are addressing that issue.
The answer is as soon as possible, because this community is very much at risk. They spend hours together in dialysis units. And so vaccine hesitancy amongst the renal dialysis patients has been a real concern for those of us working in the hospital. So the time to give it is now. Doesn't matter which day they dialyse. The other questions about the cardiac complications, I think there are no contraindications if you have a pacemaker or I'm assuming WPW is Wolff Parkinson White. We are respiratory physicians, so we don't know all the other aspects of health always. These are not contraindications for vaccination. Our real difficulty in the hospital at the moment when you have 160 patients is we can't think of a good contraindication for the vaccine at the moment. This is a vaccine preventable disease and we're seeing very sick people.
Any side effect? Receive COVID vaccine within a month of recovery. The recommendation is that patients should not have their COVID vaccine within a month of recovery, both because they should have their own immunity and also it can really cause issues given they've got their own immune response happening at that time. Patient age 35 developed petechial RAS post and her D-dimer was still 0.76 4 weeks post-vaccination. Petechial RAS post-Astrazeneca vaccination is still... I would have thought if someone's had the first vaccine, they should certainly have the second vaccine to complete their immune. And I mean, if it's thought that she had a reaction to the AstraZeneca vaccine the first time, I'm not that familiar with a rash or as a contraindication to having the second vaccine.
Again, the question has arisen again after someone's had COVID. When do you vaccinate? Somewhere between 1 month and 6 months post-infection, we will be watching out for definitive guidelines on that. They're likely to have some immunity from their convalescent state, so there's not a rush, but it probably will augment that immunity and then they will be in the best possible state of protection. The combination of a previous COVID infection plus a booster dose of vaccine is thought to be a good combination.
Hand it over to Professor McIntyre.
Legal people of the Eora Nation, which is where I'm speaking from. Good evening, everyone, and that was really interesting to hear Hima's talk. Okay. I'll give you a bit more of an overview of some of the more recent data on the vaccines. This is just a reminder of the phase 3 efficacy data. And you can see the general trend that the mRNA vaccines have high efficacy, short term anyway, followed by the protein vaccines and then the adenovirus vectored vaccines, except the Russian Sputnik vaccine, which seems to be an outlier, and then the whole virus the killed whole virus vaccines made by Sinovac and Sinopharm. The Sinovac doesn't seem to be so good, but that trial was done in Brazil, where the P1 variant or gamma was dominant at the time. The colors here are the different, the blue is the D614G, which was dominant last year. The orange is the alpha or B117, and the gray is the beta, which is the South African strain. You can see that AstraZeneca has very poor efficacy against the beta. And of course, as Hima said, the Delta variant has kind of swept the world since about April, May. It caused the epidemic in India in March, April, and then it kind of became the dominant strain worldwide. Because it's so much more contagious, with a R0 estimated to be about 6.5, that means the herd immunity threshold required for Delta is much higher than for Alpha or D614G. So probably we need more than 80% of the whole Australian population immune, and that includes children. The 70 to 80% targets that we're talking about correspond to about 54 to 64%, 56 to 64% of the whole population. And that's not enough for Delta. So you really need more than just the vaccine right now. The Delta variant also has vaccine escape with reduced vaccine efficacy compared to past variants, and the efficacy wanes by 6 months after 2 doses. I'll show you some data in a bit. Premature lifting of restrictions at the kind of levels we're talking about for the targets will likely result in a resurgence, and I'll show you some modelling we've done on that at the end as well. And some other interesting data that's come out of a study in China is that over 70% of infections from Delta arise from asymptomatic transmission. So the previous variants, that was around 30 to 50% at the most. So there's much more transmission happening when people are asymptomatic. The other difference with Delta is that, when we had the Alpha variant that was dominant from about September till May, vaccine breakthrough infections were not thought to be infectious, right? The viral load was much lower. It wasn't thought to be clinically important. But with the Delta breakthrough, the studies have shown that the viral load is the same, whether you're vaccinated or unvaccinated. So people who've got Delta breakthrough infection are thought to be as infectious as unvaccinated people. And that, of course, makes it harder to control. But the good news is that, the vaccine pipeline is not static. What we've got today is not what we'll have tomorrow. Very soon, I think, by the first quarter of next year is my guess, there'll probably be Delta matched boosters. We're already seeing boosters, 3rd dose boosters being rolled out in Israel, the US, the UK as well for people over 50. And that changes the game a little bit. It brings up the efficacy and the durability of the immunity. There's also research showing the spacing of doses makes a difference. The longer you space it, the more robust the immune response, even for the Pfizer and the Moderna. 3 weeks doesn't, it's possible that if you space the Pfizer at 6 weeks, as we're doing now in New South Wales, it may not wane as quickly as well. So this is from a preprint study that's just come out from the US, which is showing the waning of vaccine effectiveness against infection at the top, and you can see quite a substantial waning for the mRNA, for the Pfizer, which is the blue, and less so for the Moderna. And that's consistent across all the studies, that the Pfizer seems to wane faster. And of course, the Moderna vaccine has a much higher dose of mRNA in it, and that's probably the reason why. This is a study again showing the comparison of the antibody response to Pfizer and Moderna. So the Pfizer is the blue, and the orange is the Moderna, and you can see that and that's a logarithmic scale on the left-hand side. You can see that the Moderna is better. These are a range of different studies that have looked at the effectiveness against Delta, and relatively quickly soon after the vaccination, so 8 to 12 weeks after the second dose, it's 88% Pfizer and 60% Astrazeneca. In Israel, this one study showed after 3 weeks, it's as low as 40% for Pfizer, Scotland 79% for Pfizer, 84%. In the UK for both vaccines combined 49 to 60%. Whoops, sorry. And then here, this Mayo Clinic study was interesting because it showed the Moderna had a higher effectiveness than the Pfizer after 4 weeks. In Qatar, again, we saw the same thing. The Pfizer after 3 to 4 weeks, only 53% compared to 84% for Moderna. Then this study from Oxford showed that the Pfizer was waning faster than the Astrazeneca, but you have to remember the Astrazeneca started at a lower point than the Pfizer. So I think that study has been misquoted quite a lot. So it's very consistent across all the studies that there is quite substantial waning of immunity and clinical effectiveness. This is another preprint that's just come out from Public Health England, and it's showing you the vaccine effectiveness after 2 doses at different time intervals, right? This is AstraZeneca at the top here, and it's giving you the age groups as well. So even in the the bottom one is 16 to 39, right? That's the youngest group. It's 62 and 65% by 9 weeks. I think they didn't have the numbers to look at it beyond that. But if you look at the 65 plus, it goes from 63.8 to 36%. This is why they're giving 3rd dose boosters to people 50 plus in the UK now, right? Because there's quite substantial waning. Pfizer, also you see a waning. The final level you end up with in the 65 plus is 55%, so a bit better than the AstraZeneca. And here you can see it visually. You can see the Moderna has more durable immunity. This is weeks since vaccination. Pfizer wanes, AstraZeneca wanes in parallel, but starts from a lower baseline. So you're ending up with much lower effectiveness, sorry. This is hospitalization, less waning for the Pfizer, for the under 65s, but for the over 65s, quite dramatic waning, right? So it's the over 65s who are really vulnerable. And then also quite a lot of waning for the AstraZeneca, and it ends up at around 60% efficacy against hospitalization. And I don't know if you can see the deaths there, but that's also waning, which is a concern. In Israel, you know, at the beginning of the year, they had the Alpha variant dominant. They got to about the target that we're aiming for before relaxing restrictions, which is 62% of the whole population vaccinated. And they saw a dramatic reduction in hospitalization and death in the older age groups who got vaccinated first. 92% protection, 95% protection in 2 different studies. And they lifted all the restrictions in June. The US did that in May, and then they had a resurgence of Delta, and the same thing was seen in the US. So they've now brought in a 3rd dose booster for 50 plus. Here's the data from Israel showing, so the red is the unvaccinated, and you can see this big surge in Delta. The blue is the light blue is the people who had 2 doses early in the year, and it's still better than being unvaccinated, but you can see quite a bit of waning. And there's the difference the 3rd dose booster makes in daily cases and severe illness. So the 3rd dose booster really makes a difference. This is over 60s. Here's a study that's just come out in New England Journal of Medicine, and basically it shows the waning efficacy over time. And in this case, it goes from 96.2% less than 2 months after the 2nd dose to 90% between 2 and 4 months, and then to 83% more than 4 months after the 2nd dose. This is a trial that's come out in adolescents showing that it's efficacious in adolescents. This is the Moderna. And then I think I'll just talk briefly about, I mean, I know Hima talked about ventilation, but really the Delta variant has shown us all over the world. There's another graph that I don't have in here, but it's a graph showing what's happening in Europe. The UK is the only country in Europe that just relied on vaccines and didn't do anything else. But countries like Germany and France and Spain and even Italy, they used the face mask mandates. They systematically looked at ventilation. So some of the European countries mandated carbon dioxide monitors at the door for businesses, for restaurants and so on, so clients can check the ventilation and see if it's good enough for them. They addressed ventilation more systematically, and all of those countries, the cases have come right down, but the UK, the cases are going right up now. So you need more than vaccines for the Delta. You can't vaccinate your way out of an outbreak. So you really do need the face masks. They do work. There's numerous studies around the world now showing that the face masks have made a big difference. In the Victorian second wave, a study from the Burnett Institute estimated they reduced the risk of infection by 40%, which is very substantial. But safe indoor air is particularly important for Delta. And there's been another study that I haven't got in here, but it's just been published in Clinical Infectious Diseases. And it was for the alpha, and we knew the alpha was at least 3 times more contagious than, 2 to 3 times more contagious than the D614G. And that study showed that the amount of virus in the air, the viral load in the air was much higher for alpha than for D614G. So it follows that the viral load in the air is going to be even higher for Delta, because we know it's much more contagious. So safe indoor air becomes really, really important for Delta, and that's everywhere, in hospitals, in schools, in homes. When you think about the households in Southwest Sydney, you know, I think as GPs, if you can tell your patients, or you know, whether they've got COVID or not, if you can tell your patients, communicate to them the importance of safe indoor air, you know, just opening a window makes a huge difference as the weather is warming up. And there's been numerous studies looking at the accumulation of aerosols when you don't have clean air coming in versus when you do. So the air we breathe really matters. And as Hima said, it's just breathing and talking. People think about it as a cough or a sneeze, but you think about it, a patient in a ward is breathing and maybe talking throughout the day. They might cough or shout or sneeze a few times, but in terms of the duration, it's the breathing and the talking that generates the most aerosols, because it's constant, right? It's this constant generation of aerosols which just accumulate. And there's been studies that show that even in hospital wards with 12 air changes an hour, you can still detect live virus in the air. Toilet flushing is the other one in hospitals, because most hospitals don't have a lid on the toilet. There's been studies that show that when you flush the toilet, there's quite a lot of aerosol. About 60% of the aerosols go above the level of the lid or the seat, and they can get aerosolized all over the room. So in terms of your GP practice, you know, have a lid on your toilet and have a sign saying close the lid when you flush, and have a can of Glen 20 in there and spray it regularly, because the toilet is. There's been a couple of studies on aircraft that showed that probably the toilet was the risk factor for transmission. And I think that's the bit that gets forgotten. You know, we hear about these outbreaks at the MCG or at the beach or whatever, but it's probably, you know, when they either went to the cafe to get a snack or went into the toilets or some other indoor space, or on the bus coming over. You know, it's the indoor spaces still that are most risky. Medical procedures, yes, of course, they are a risk. I'll just I'll skip this just in the interest of time. Just, you know, there's a lot of virus in the air. Beware the air you share. This is a nice study that's from a classroom, and it shows the difference that an air purifier makes, right? And I mean an air purifier with a HEPA filter. So the dark red line is the dose the cumulative dose without a purifier, and the dotted red line is the dose of RNA, viral RNA without the purifier, right? So you look, x-axis is time, right? So if you're in there for 10 minutes, you're probably okay. But if you're sitting in that room for an hour or 2 hours, your risk just progressively increases over time. And this is the difference that an air purifier makes. It just dramatically reduces that risk. So you really need to think about the air that you're breathing. Oops. This is a nice study that showed that actually a cough generates more aerosols than endotracheal intubation. Extubation produced more aerosols than intubation, but a cough was still greater, right? So there's a lot of, I guess, misconception about aerosols in the clinical setting. This is the graph I was talking about the UK and all the other European countries. Now that's to September the 8th, and you can see, so the UK just went for, yeah, we'll just vaccinate our way out of this and we'll be right. And and they didn't vaccinate children, of course. They've just introduced 1 dose for children 12 to 15, but they made a decision not to vaccinate kids when most other countries did make the decision. And you know, a lot of that burden of disease is in kids. So this is just, I'm just going to show you a bit of the modeling we've done. This is a paper that was published maybe the beginning of this year, yeah, earlier this year, which this is just to show you, this is like, just say this is the epidemic peak and the epidemic, the difference that vaccine efficacy makes, right? And there is difference in efficacy between vaccines. So if you've got a really high efficacy vaccine, you can actually control it really well. But if you're using a vaccine with lower efficacy, you're going to end up with a much bigger burden of disease. So the vaccines we choose do make a difference. This is a little bit out of order, but this is just to show you the adverse events following a heterologous prime boost, and with the Astrazeneca followed by the Pfizer. And generally you get an increase in systemic and local reactions, but not serious reactions. However, this study was only a few thousand people, so probably not big enough to capture really rare side effects. So it'll increase the reactogenicity, but probably not, you know, okay from a safety point of view. Do vaccines stop transmission? Well, the mRNA vaccines do. You know, they are highly effective against transmission because they can prevent infection altogether. And I think with the 3rd dose, you could get it back up to the sort of efficacy we were seeing early on. The AstraZeneca, not so. In the phase 3 trial, there was 22% efficacy against asymptomatic infection. So you've got to prevent asymptomatic and symptomatic infection. But the studies from Israel showed over 90% effectiveness against asymptomatic infection for Pfizer. So herd immunity is a function of the R0, and it depends on the level of immunity you need in the population to stop transmission. It depends on the R0. So the higher the R0, the higher the immunity you're going to need. And the immunity is a function of the vaccine efficacy and the coverage. So this is from one of the studies we published. And if you've got a vaccine that's got 95% efficacy, which is what the Pfizer and Moderna looked like against all infection, not against symptomatic infection or death or hospitalization, you need it to be effective against all infection, then you actually only need about 63% of the population immune for herd immunity. So the current targets would do it. But unfortunately, we've got Delta now, which brings it down to, which probably means we're somewhere around here. We probably need 86% of the whole population immune, which means, you know, we've got to vaccinate kids, maybe 75%. Actually, in San Francisco, they achieved 70% of the whole population vaccinated. It's the most highly vaccinated city in the US. and they've actually started to see a downturn compared to the rest of the US, but they've also used mask mandates and ventilation and a layered approach to controlling it. So we don't know yet how often you may need boosters. My feeling is it's going to end up being that the primary vaccination schedule is a 3-dose schedule. I think that's where we're going to end up. Many vaccines need a 3-dose schedule, you know, so that's nothing unusual. There will be boosters that are matched to the Delta, and that means the vaccine efficacy will go right up to that 95% level again for the mRNA vaccines. The vectored vaccines have a disadvantage because the more boosters you have to give, the body will develop immunity to the vector, in this case, the adenovirus, and then that will reduce the efficacy over a longer period of time. Of course, there's a lot of work going on to develop a pan-coronavirus vaccine, and that'll be like the holy grail. If we get that, we don't have to worry about variants because it'll cover all of them. Vaccine passports, I think, are inevitable internationally. Looks like they probably will come in domestically as well. In terms of international travel, I think the vaccine you receive will matter, and whether or not you've had boosters may determine the kind of quarantine requirements that you need. And of course, we've got a precedent, which is yellow fever. I just thought I'd mention the Immunization Coalition has done a whole bunch of nice videos for patients, for the community, including in Arabic, on vaccination and getting vaccinated. So I won't play it now, but it's there if you think it's a good resource. There's a whole bunch of really nice multilingual resources developed in Melbourne as well. And I can send the link later to Alison if necessary. So I'm going to finish off by showing you this modelling we've just done of the New South Wales roadmap. So we basically took a published and peer-reviewed model, the one I showed you before for COVID vaccines, and we updated it for Delta. I'll just start by saying that this is an epidemic disease. It's never going to be endemic. Endemic is the green line up here. Doesn't change much. If it changes, it's over years. Epidemic, it goes up and peaks and comes down in a very short period of time. And that's the kind of pattern that disrupts health systems and disrupts society in a major way. And it's like measles. You know, we still see outbreaks of measles, even though we've technically eliminated measles in Australia because people travel, they bring it back, it causes an outbreak, but it never takes off and goes on and on and on because we have achieved herd immunity with vaccines for measles, as we have for polio. So I think SARS-CoV-2 will always find pockets of unvaccinated people, and it'll cause outbreaks. But hopefully when we get to that point when we've got high levels of vaccination, it'll be more like measles than it is at the moment. But at the moment, with 40% of the population unvaccinated at the time of the proposed lifting of restrictions, the virus is just going to spread. You know, the virus wants to spread. It's going to find those unvaccinated pockets of people and spread. So modelling is a science that we use to predict future outcomes under various conditions, and infectious diseases are really suitable for modelling. And the purpose is to show the best and the worst case scenarios and scenarios in between. So to show a range of scenarios under different conditions, which accounts for uncertainty. And that can inform the choice of strategy for decision makers. And you could really model an infinite number of scenarios, but in this case, we've just done 6 scenarios. None of them are a certainty, okay? So none of them are telling you this is going to happen. It's just showing you possible scenarios that could happen depending on different decisions. So that it's based on this paper that we published. We used a R0 of 6 for the Delta. We incorporate in the model progressive increase in vaccination, mask use, testing, tracing, and restricted movement. We assume the vaccine efficacy against Delta to be 31% after 1 dose, and for both vaccines, and 88% and 67% after 2 doses for Pfizer and Astrazeneca, but 90% plus efficacy against hospitalization, ICU, and death. We fitted the model to the actual notified cases in the red there, and to estimate how many cases we might have when we lift restrictions, we think around the middle of October, which is when we expect we might get to that level of 70%. So there's 6 scenarios here. Scenario 1, the first freedoms are granted on the 18th of November, and movement restrictions, which is the big thing here, goes from 60% to 46%. But we don't give any new freedoms on November the 6th when we get to 80%, but you get more people eligible for freedom. So the movement restrictions drop to 44%. Scenario 2 is the same, but with enhanced contact tracing. So it goes, at the moment, we estimate that contact tracing, effective contact tracing is only about 20%. We know the average time to notifying people they're a contact is about 11 days at the moment in New South Wales. And of course, most of the infections will happen within a day or two, right? Really quickly. So there's a contact traced days after you identify the case is not effective contact tracing. You have to trace them really early so you can quarantine them and stop them infecting other people. So we estimate it's about 20%, and that's highly influential in controlling the epidemic. If we increase it to 50%, and the other thing they plan to do according to the roadmap is drop the outdoor mask mandate. So we've got the mask mandates dropping from 65 to 50. No new freedoms, same as the other one, but more contact tracing. Number 3 is where you have first lot of freedoms on October the 18th and more freedoms on the November the 6th, with contact tracing remaining low, and scenario 4 the same, but with contact tracing enhanced. Scenario 5 is where you keep the restrictions till you get to the 80%, but you have a very drastic drop in movement restrictions, 60% to 30%, right? And drop in masks and contact tracing the same. And the last one is same as 5, but with enhanced contact tracing. So in this case, we modeled that in 3 of those scenarios, you would get to code black conditions. And scenario 3 was the worst, where you've got 2 phases of lifting restrictions, that 70% of adults and 80% of adults. So, and you don't do anything about the contact tracing. And you get, about 5 weeks of code black conditions. Scenario 4, where you enhance the contact tracing, where you keep the restrictions till November. That's enhanced contact tracing. Yeah, you get 1 week of code black. And then scenario 5, which is where you keep the restrictions till you get to 80%, but you have a drastic drop in movement, increase in movement of people. That gives you 4 weeks of code black, and 6, you don't get to those code black conditions. Remember that ICU capacity is an important determinant of the case fatality rate. We saw that in Europe last year. The countries that ran out of ICU capacity, the case fatality rate just went through the roof, because the minute you can't give people either ventilation or CPAP or even oxygen, then they start dying because you can't give them the care that would save them, right? So it's really critical to avoid those conditions, because that's when the death rate will go from the 0.5% to much higher rates. That's the modeled curve for hospital beds. And you can see the ones where you relax the restrictions later will push the peak to January. But in the ones where you relax restrictions in October, the peak lands smack bang on Christmas Day, around Christmas. There's the ICU, and the 600 is 600 patients with COVID, assuming there'll be about 300 non-COVID patients needing ICU as well, which is what the ICU specialists who help with this model advised. So you've got those 3 scenarios where you get to code black conditions, and the other scenarios avoid that. So it's really, the choices are between not so great and terrible. we're in a terrible situation because there's so much community transmission. And essentially, if you start dropping restrictions, it's like, the public health measures, the Delta variant is so infectious and so difficult to control. Think of it like a set of scales. You've got the virus on the one side, and you've got all the public health measures on the other, the movement restrictions, the masks, the contact tracing, the testing. If you take out something from the public health measures and you've still got a lot of virus there, then the virus is going to win. It's going to just dominate, right? So if you take out the movement restrictions, you have to increase something else to keep it under control. You have to get your contact tracings right up again. You can't afford to let the testing rates drop. If the testing can't keep up, you'll also be in a bad position. You can't drop the mask mandates. You've got to use everything else to enable those freedoms to end up with not so great rather than terrible. But that's unfortunately the situation we're in. And on this basis, we've recommended not to do a two-stage relaxing of restrictions, just do one relaxing of restrictions and keep a reasonable level of movement restriction in place. So not 60%, but around 40%, that could still manage things and avoid really a bad surge. But whatever you do, we've got a lot of community transmission. There will be another peak that occurs around the middle of December. If you release in October, if you release the restrictions in November, it'll happen in January. So yeah, really, that lesson from the UK, that don't just rely on vaccines. That it's, the Burnett Institute released some modelling yesterday, I think, which showed that it wasn't the vaccine that was controlling the epidemic in Southwest Sydney. It was all the non-pharmaceutical interventions. You think about it, the virus takes a day or two to spread. The vaccine takes 2 months to take effect. One dose is virtually useless. You need the 2 doses. That's 6 weeks plus 2 weeks to get your full immunity. There's no way in the world the vaccination can control the epidemic. If we had vaccinated everyone earlier in the year before the epidemic started, that would have made a difference. But in this particular scenario where we've got a lot of community transmission, we absolutely need all those other measures to keep it in check. And when we get to those high levels of vaccination, if we can give 3rd dose boosters, I mean, I personally think healthcare workers should get a 3rd dose booster. We've seen health workers in Sydney get quite ill after 2 doses of Pfizer. So, and the stockpiles of airborne PPE, they will run out very quickly if this goes on for months and months. That, we've got to make sure we've got those stockpiles adequate. Yeah, we assumed testing rates were high in this model. So if we're wrong and the testing rates have dropped off, the epidemic could be worse. The Doherty model that's talked about assumed that the testing and tracing were all fine, whereas clearly the tracing is not fine. It's not keeping up at all. And we didn't include the increase in case fatality after ICU care can't be provided. So that's it. I'm sorry if that was not a very happy note to finish on, but I think that's, yeah, as I said, it's a situation that might be not so great or terrible. Let's hope it's not so great and we get through it and get high levels of vaccination. But for the medium term, we need those other measures as well.
Raina, can I thank you for your talk? But as the one of the lead organisers at Liverpool Hospital Respiratory Department and COVID response, I feel like going and having a good lie down now.
Yeah, it's, we don't even have to model. We can look at other countries. So the UK, the US and Israel all lifted restrictions at the time when they reached about the target we're aiming for, right? 70 to 80% adults is about 56 to 64% of the whole population, right? So, and they all had a resurgence. The vaccine at that level of vaccination, it wasn't enough to control the Delta. And if you relax the virus just wants to spread. It wants to spread. It's going to find people to spread to, it's going to go to remote Aboriginal community. We've already got outbreaks happening in regional New South Wales and towns in lockdown. I don't think Dubbo Hospital has much capacity now, but if Dubbo Hospital's down, someone in Walgett can't get medevaced because there's nowhere to go. We're not in Europe where it's 30 minutes to the next town. There's like vast distances between towns. People in regional New South Wales are particularly vulnerable because they're not going to be able to access the kind of care they need in the same way that people in the city can, yeah.
And for those of you working in Sydney Southwest, whilst we've done a great job in building up Liverpool's capacity, we are close to capacity. We've gone from 1 ward to 7. 9 is the stretch target, but honestly, beyond that, we don't have it. There aren't any more rooms in the hospital to build to. So we are 8/10 of the way to our maximum capacity. And if this is the beginning of the uptick, we can't help you very much more than that, I think. So it is very sobering to know that we've done so much work and we've gotten so far and done it well, I think, but that we're almost at the peak that we can deliver.
Yeah, so there's a lot of public talk about the peak, it's peaked, or it may well have peaked, but that peak is under the current restrictions. And that's what Alberta saw, right? If anyone's followed what's happened in Alberta and Canada, they also went for we'll just vaccinate our way out of this. They got they had a first peak earlier in the year. It was up there, it came right down, and they said, yay, let's have a great summer. And their health system has collapsed. It's absolutely collapsed. They had a massive resurgence, and, but they, of course, decided they didn't need anything else, no masks, nothing. I think the New South Wales government is definitely going to keep mask mandates and various other measures. And I don't think they're going to just release restrictions to the point of complete freedom. I think they're very aware. They've seen the modelling from multiple, I can guarantee, like what we looked at was the roadmap, right? And I can guarantee you that the Doherty model and the Burnett model wouldn't be very different to what we've shown. They're the same kind of models. So I think hopefully that'll all be taken on board, and it'll be a more cautious kind of relaxing of restrictions. Yeah. And the problem is the epidemic's growing faster outside of Southwest Sydney than it is in Southwest Sydney, right? I mean, it's now taking off in the eastern suburbs again, and in regional New South Wales, and all along, for probably the last month, it's been growing faster outside of Southwest Sydney than in Southwest Sydney.
And that has repercussions for us because they've been absorbing some, I wouldn't say a large portion, but we're getting outflow to other parts of Sydney. Once they fill up and we have nowhere else to put our ICU patients, our low acuity patients, that will get us to that limit where we're an overwhelmed health system. Yeah. Mm-hmm.
I mean, I just personally think it's like most health workers, hospital health workers got vaccinated in February or March. Yeah. I just think it's urgent that you all get a 3rd dose booster.
Do you have any influence with somebody? Because
we've been lobbying really hard. We formed this collaboration across the whole country called AusSage, and we've lobbied for it. Other AMA has lobbied for it. But I know that ATAGI is considering it, but their highest priority is immunosuppressed patients. I don't think they're really thinking about it in terms of the health system. Forget about whether they care about health workers getting sick. If we want the health system to stand up, we've got to protect every healthcare worker maximally.
I totally agree.
And that includes GPs. I mean, GPs are the front line, you know?
So it was very sad that GPs weren't in the first rollout. I only got vaccinated when I get vaccinated because we had so much spare Astrazeneca going around because people didn't want it because of the massive mess up in communication and the confusion that was caused by the rollout. So people didn't want an AstraZeneca. So I had a spare one. That's the only reason I got vaccinated as soon as I did.
Yeah.
It's a ridiculous state of affairs. And it seems that it's getting missed, isn't it, with the press conferences pretending that the health system was fine when I was getting inside information that no, there are now 5 wards, 6 wards, 7 wards. That's not a health system that's coping well. That's a health system that is really under strain. And absolutely right. Doesn't matter how much physical space there is if you've got nobody to look after the patients.
Exactly. Yeah. Yeah.
And
we're talking about, you know, and the other thing that's happening in this, from my own, you know, people that I went to uni with and so on, talking to them, the ones that are still working in hospitals, you know, you've got highly trained cardiologists being asked to go and do COVID ward duty, you know. Are we going to lose a whole generation of really highly trained, you know, clinicians? Because I don't know.
Can I tell you, that's been one of the successes at Liverpool Hospital. It's been a joy to have the highly trained cardiologists working alongside us, and they've been diagnosing the cardiac complications. So
that's true. That's true.
It's actually been a huge success.
Yeah.
But you know, they've got a workforce problem, right? It's a workforce problem. We've got hundreds of overseas trained doctors who've passed their AMAC, right? They could be given registration to come and help with that surge. I think there was a plan for that last year at the beginning. I don't know where it's at. That will be a federal thing. Yeah, I don't know.
I'll draw us to the couple of the questions in the chat. So Diep Jiang asks, should air purifiers be used in GP practices? I would suggest they should be in classrooms and they should be in offices where we're forcing people back into those. Yeah. We still want everybody we can possibly get to be managed by telehealth. Air purification is where you've unavoidably got people all together. So I would suggest, if the panel agrees, that's probably where to, you know, I've got 2 kids. One's going to be going back in term 4. That's the plan, right? You know, they've only just got vaccinated. Most of their friends, most of the kids going back to school will only have had 1 vaccine by the time that rolls out, maybe just have their second. And what you've just said is that's not going to be enough to prevent spread in the classroom. And although they may not get sick, that's where our spread is going to be, is back in the classrooms.
Yeah, we need windows open, air purifiers, you know, parents and teachers vaccinated as a priority. It's been so hard for teachers to get a vaccine, you know, until quite recently. You can get these CO2 monitors. They're cheap. You know, I got this one for like $60 on Amazon. And I take it everywhere to check what the ventilation's like, you know. When we were sort of told we had to come into the office earlier this year, I took this along and I checked out the ventilation everywhere, and fortunately it was okay. But if you're in a building that's more than 5 years old, probably the ventilation won't be okay. But if you've got windows, and if you can open the windows in a GP practice, if you've only got 1 window, a fan makes a big difference. You can use a fan to push the air out. But yeah, just keeping windows open makes a dramatic difference to accumulated aerosols. And some portable air purifiers with the HEPA filters, they're not expensive. You can get them from, I don't know, $300 to $700 from Bing Lee. I mean, I'm not spruiking Bing Lee, but that's where I bought my one. I've been using them for years for bushfire smoke and asthma and stuff. Yeah. So
we're at 8:30 now. I thank all the presenters. Zinta Harrington, thank you. Thanks, Hima. Thanks, Raina, and all the you guys now will do with all the attendees to hang about and do the feedback session and stuff like that with PHN.